Okay, great. And I realized when we were working on the flyer for this talk that I need to change the title of talk. So I'm just going to point out the term differential diagnosis is a medical term that some of you may know, and it's what we use to say, well, we're trying to figure out what the different causes of something is. So if somebody comes in with chest pain, the differential diagnosis of chest pain includes a heart attack. So there are different causes of chest pain. So really all I'm talking about here, what are the causes of dementia, and what's the difference between dementia and things like Alzheimer's disease. I'm happy to pause anytime during the talk for questions. And I'll have a couple of polls that I'll put out to the group. I talk a lot about medicines and tests, and I don't have any conflicts of interest. I don't participate in any industry sponsored anything. So that's a good thing, hopefully, in terms of my ability to talk about these things. The things I would like us to achieve with our talk today is to understand what the difference is between dementia and Alzheimer's disease. What are the common causes of dementia? What's the underlying pathologies, the underlying causes of the different types of dementia, in particular, Alzheimer's disease, frontotemporal dementia, and dementia with Lewy bodies? And what are the risk factors for Alzheimer's disease in particular? And what are the treatments in particular for Alzheimer's disease? So this is the slide I always start with when I give talks, and it's the pie graph of the different causes of dementia. I term it estimated only because this is a mixture of a bunch of different studies, because not all the studies included all of the different causes. In particular, the one called LATE, which is a long acronym for limbic predominant age-related TD43 encephalopathy, is a very recent addition and a recent finding, and was not included in many of the older studies. But the points that I'll make are the main cause of dementia. So the main piece of the pie graph is the Alzheimer's disease slice. That's the blue. The mixed causes next to it in the dark green are mostly Alzheimer's disease plus strokes or hardening the arteries. And so most of the mixed causes are also Alzheimer's disease. So that means that 2/3 of people with dementia have Alzheimer's disease. The term dementia is not very helpful. It just means bad memory as we age, and memory that's gotten bad enough that it impacts our ability to live our life. And so the term dementia is not a diagnosis. And I always tell people that if you go to the doctor and the doctor says you have dementia, then you really should go back to the doctor and say, well, what's the cause of the dementia? Because there are different causes, different treatments, and different prognoses depending on the different causes. But I also want to point out that for most people, the dementia that they have is caused by Alzheimer's disease. So that means that if somebody has memory problems that get worse as they age to the point they can't manage their finances, they can't drive a car, that if they came to see me in the clinic and I asked no questions and did no tests, and I said, I think it's Alzheimer's disease, I'd be right about 2/3 of the time. It is by far the most common cause of dementia. And that's why many people, and even doctors and other providers, will use the term dementia and just believe it means Alzheimer's disease. But that's not the case. There are hundreds of things that cause dementia, that cause bad memory problems as we age. And that's why it's important to try to figure out the different causes. Now, even though I said there are really hundreds of causes, there's a few that are the most common. And so those are the ones that I want to talk about today. So Alzheimer's disease is the blue, and Alzheimer's disease plus strokes and a few other things are the dark green. The next most common cause is the light green. That's the vascular dementias. This really is any blood vessel problem of the brain that injures it. It could be a big stroke, a lot of little strokes, even bleeding in the brain. And I'll talk about that later. It's interesting, if you look at the studies from Europe and other countries, the vascular dementias seem to be a little less common. And there's some theory that here in the United States, our lifestyle is fairly unhealthy, and maybe we have higher rates of the vascular dementias than other areas of the world. The next most common is this late I mentioned before. TDP43 is a protein that deposits in the brain. We don't really understand much about this protein and much about this concept of late. But one of the reasons it's called late is it tends to also occur in people who are older. When I say older, I mean late 80s or early 90s. So it likely is not a main cause of dementia in people who are younger. It also seems to coexist with other things like Alzheimer's disease fairly frequently. So it may not be a problem on its own. The next most common cause are the Lewy body dementias. We'll talk in detail about those. Those are things that look like Parkinson's disease. A very uncommon cause are the frontotemporal dementias that we now call frontotemporal lobar degenerations, which is sort of a mouthful. Even though they're uncommon, they're quite striking. They tend to present with prominent behavioral changes that are very unusual, problems with difficulty with speaking and coming up with words, and sometimes even can look like somebody who has ALS, which is Lou Gehrig's disease. Because they're so striking, and it's important for us to talk about them because they really are a challenge to diagnose and to treat. And if you make the wrong diagnosis and presume it's Alzheimer's disease, and it's actually one of the frontotemporal dementias, then it makes it very hard to treat them appropriately. All right. I can go to the next slide. There we go. So in terms of diagnosis, and I often get questions, well, how do we come up with a diagnosis? This is a rapidly evolving process. And you can see I put current in quotation marks because the current guidelines for diagnosis actually date back to 2001. Really in no other area of medicine are we using recommendations from over 2 decades ago. And you can see that they are pretty basic. So when somebody comes to see me, I get history from the person with memory problems and someone who knows them well. The corroborator, which is someone who can provide collateral history, meaning information about the person, is critical. Things like Alzheimer's disease affect someone's memory, so it's hard for them to remember that they've forgotten something. But more importantly, it also changes their brain so they're not aware of the memory problems they have. And it's a pretty common and stereotypic scenario when somebody comes without their family. So when I see somebody with early Alzheimer's disease by themselves, the story is always the same. They come in and say, well, I think I have a little problem with my memory, but I'm not worried about it. Everything's going fine. I'm fully functional and I don't know why I'm here. It makes for a very vast visit because there's really no history to obtain. But when I eventually hear from the family, they of course tell me much more. They say that the person's become forgetful over the past 3 or 4 years. It's gradually progressing. They now need assistance with medications, and they've gotten lost while driving and have to call for help. And if I don't get the information from the person, the collateral informant, as we call them, I'll never know really what's going on. The other point I'll make is it's not the person in denial. And it's very upsetting for families when they think their loved one with Alzheimer's disease or other dementia is in denial. They say the person just won't admit they have a memory problem. We can't have a conversation about it. But it's really not denial. Denial would be if somebody has cancer and won't admit it, and their cognition, their thinking is fine. So somebody with Alzheimer's disease their brain is not aware of the memory problems they have, and so they're just not aware of it. And it's important that we point that out to patients and their families so they can have a better relationship together and not be angry at their loved one. So that's the most important thing, the history from the patient and somebody who knows them well. The next thing is us examining them. We look to see, are there signs the person's had a stroke? Are there signs that they could have something like Parkinson's disease? And cognitive testing. Here in our clinic, almost every patient gets formal neuropsychological testing with one of our 5, 6 neuropsychologists that we have. And that's critical for several reasons. One is that it's very difficult to tell if the changes somebody has in their memory are part of normal aging or if it's more than that. All of us as we age have a decline in our thinking and in a pretty reliable way. It takes us longer to learn something. We have the tip of the tongue phenomenon where we can't think of a word or a name. And because those are normal and expected, if somebody comes to see us with those types of changes and we call it dementia, then we've made a wrong diagnosis. Maybe they don't actually have Alzheimer's disease. And so the neuropsychological testing is critical because that's how you tell. The next most important thing is to make sure it's not something else. So we do that by evaluating for depression, because depression and anxiety can affect memory. We make sure we look for medical causes with blood work, and we make sure every patient has a brain scan. Ideally, an MRI is a much better picture of the brain. And that looks to see one of three things. One is, has there been a stroke? Is there a brain tumor or some sort of brain mass? And is there too much fluid on the brain? Those are all treatable other causes of dementia besides Alzheimer's disease and some of the other progressive disorders. That's the current criteria, and none of those tests are specific for any cause of dementia other than strokes. So none of those are tests specific for the causes of Alzheimer's disease or the causes of the Lewy body disorders or the causes of frontotemporal dementia. And we actually now have tests that look for those, and I'll point those out. And the reason I say that, it's very likely in the near future, we're going to be using tests that are specific for the different causes of dementia and not just trying to look for something else. The Alzheimer's Association has been very helpful in providing resources for primary care providers and anyone else to try to make a diagnosis in the medical field. And I put that a little algorithm they have over on the right, and they've made those available for providers to use those resources, which is a really wonderful thing, because oftentimes it's hard to get those survey instruments and cognitive tests to use. I'm going to stop just to see if there's any questions and to take a sip of my tea before I go on to my next slide.
I don't see anything in the chat.
Okay, then I'm going to keep going. So I have several cases, all based on real people, but obviously I've changed the information so we can't identify who they are. But they also are typical cases that I see. So they're typical for other patients with similar problems. So Harold is 67, he comes with his son. They're both concerned that he has Alzheimer's disease, although his son is more concerned than he is. Harold often misplaces his keys, and when he does, he often can't find them. And it means that sometimes he just can't do the errand he wants to run. He's repeated himself more and more. It seems like his short-term memory has gotten pretty short, meaning that if his son has a conversation with him and says, you know, we're going to the doctor tomorrow, Harold the next day often doesn't remember that. He has difficulty coming up with words, so he often pauses in conversation and gets stuck when he can't think of the word. He's cut back on his driving, and when he does drive, he's gotten lost and had to call his son several times to help figure out how to get home. And his son has started to help pay the bills now. When you examine him, he clearly seems forgetful and has a hard time coming up with words. The MMSE is one of those screening cognitive tests that I mentioned on the prior slide. The Alzheimer's Association has some of the resources for. 26 out of 30 means that person may have some change in their memory that's more than normal aging. So you get concerned and you order a brain scan. And this is an MRI on the left. The way they show these, it's like they pretend to slice someone's head like this, and in the scanner, they're on their back looking up the ceiling, so it's like they're slicing their head down this way. And you can see his eyes and nose at the top of the screen. That's the front of his head, and the back of his head is the bottom of his screen. And you look at the pictures and you say, well, it looks like his brain has shrunk a little bit, but I don't know if it's more than I would expect for his age. And the MRI places now have this fancy computerized tool that actually uses a bit of AI in a very focused way to measure different parts of the brain. And it measures the memory center of the brain and it plots it out on this graph. We want our memory centers to be what we'd expect for our age, so between 25th and 75th percentile. If the memory center size is below the 5th percentile, then it's very small. And it tells us the memory center, the hippocampus, which is the memory center, has shrunk quite a bit over time. And there's definitely something going on. The most common cause of shrinkage of the memory center of the brain is a particular cause of dementia. And so I'm going to let you think about what that might be, because I'll ask the question in a minute. Actually on this slide. So this is our first poll. So let me launch the poll. Your job is to figure out what the cause of dementia is. All right, so I'll let you guys take a few minutes and think about it. All right, most people have responded, so let me show the poll. All right, so hopefully you can all see that, and the majority of people said Alzheimer's disease. The next highest vote count was for mild cognitive impairment, which I'll talk about in a minute, in why this person falls in the category of dementia as opposed to mild cognitive impairment. And Harold does have Alzheimer's disease. And the question really is, how do we get to the diagnosis with those tests that he had, and how certain can we be? So that's what I want to talk about next. There we go. Okay. The current criteria for diagnosis of Alzheimer's disease dementia, which again is a mouthful, I think we're eventually going to change that name just to Alzheimer's disease. This is way back in 2011, so not a lot more recent than the recommended workup. And it puts Alzheimer's disease diagnosis into one of several categories. And we're supposed to say this when we make a diagnosis, and it's just telling the referring physician how certain we are. We either think it's probable, it's most likely Alzheimer's disease, it's possible. We use possible when it's often the mixed causes. We think, well, there's also vascular disease of the brain, strokes, or maybe it looks like something else. And then there's these categories of evidence of the pathophysiologic process. And those are the tests that we're now using that are specific for Alzheimer's disease. And then, of course, there's number 4, which is proven Alzheimer's disease dementia. And that really is only if there's a brain biopsy, which we don't do anymore, or they come to autopsy. Because these new tests that I'll mention are so accurate, we probably are going to start saying that we can be pretty certain about Alzheimer's disease during life. I suspect many of you have heard that we just can't be certain if somebody has Alzheimer's disease or not during life. And that used to be true. We used to only be 60 or 80% accurate, but with the new tests, we're much more accurate. And so I think we're going to change and start saying things like, we're pretty certain about a diagnosis of Alzheimer's disease. And so the question is, how certain can we be? And as I mentioned, the existing criteria are really fairly inaccurate, meaning that if they don't all point in the same direction, so if the story doesn't fit to Alzheimer's disease, if the MRI doesn't fit for Alzheimer's disease, we're pretty uncertain about a diagnosis. If somebody comes to a clinic like ours and we don't do these fancy tests that I point out at the bottom, but their story is typical for Alzheimer's disease, their MRI is typical for Alzheimer's disease, and the memory testing is typical for Alzheimer's disease, we're about 80% certain. But even 80% is not that great compared to other diseases. Diabetes is a great example, a simple blood test, and we can be very certain whether somebody has it or not. And so we really have needed to come up with a test that allows us to be much more accurate. And at this point, there's 3 tests that are either out or coming out that are quite accurate. The first is a lumbar puncture. That's a spinal tap. And that's actually done in the lower back, but the same fluid that surrounds the spine also surrounds the brain. And when we measure the proteins that we think cause Alzheimer's disease in the spinal fluid, we can be very accurate. In fact, we think that the spinal tap test results are about 90 to 95% accurate. And I just printed a report for a patient that looks like Alzheimer's disease. Obviously, I removed all the patient information, but we look at the amyloid beta 42, a protein called tau, the same protein tau with a modification in a phosphorylated region. And then we look at a ratio between some of those proteins. And if all of these proteins point toward Alzheimer's disease, we're very certain, 90 to 95% certain that person has Alzheimer's disease. And that's a dramatic difference from where we used to be, especially for these confusing cases where we were only 65% certain. On the right is a picture of an amyloid PET scan showing that as there's more amyloid beta in the brain, in the pictures of the brain autopsy on the right, the PET scan shows the amyloid in the brain. These amyloid PET scans are FDA approved, but not covered by insurance. So while I can order them, I don't, because insurances won't pay for them. I used to think that once insurances started paying for the amyloid PET scan, we would be doing all amyloid PET scans and no lumbar punctures. The reason I think that's not true now is because there are blood tests that have come out over the past several years that look to be quite accurate. Right now, they're not in widespread use, and the most accurate ones are not actually approved yet. But I think in the next several years, they will be approved. And for the vast majority of patients who come to see their PCP, they can order a blood test. It's not quite as accurate as a spinal tap, but it's actually more accurate than the existing criteria. And I think that's going to be a dramatic change for us in medicine, where it's just like for diabetes, your primary care provider can order a blood test and be pretty certain whether it's Alzheimer's disease or not. Oh yeah, I was just going to remind myself to talk about the blood test, but I got ahead of myself. I think there might be some questions. Should I pause for questions or keep going, Katie?
Let's pause. We have a few questions.
Okay.
A quick one, just a quick definition of dementia again.
Sure. Yeah, the term dementia just means bad memory problems. So the memory changes are so bad, they interfere with somebody's daily life. So if somebody can't remember how to drive somewhere, can't remember to pay their bills, they by definition have dementia. It doesn't tell us the cause of dementia. It just tells us they're in that category of dementia. And then it's our job as the medical provider to figure out what the cause of it is. It's a little bit like going to the doctor with foot pain. And if the doctor says, I diagnose you with foot pain, it's not helpful, right? So you want the doctor to tell you the cause of the foot pain. The same is true for dementia. It's just a fancy medical term for bad memory problems. And so that's one of the ways that I describe dementia, but it's a good question because it's very confusing, and we in medicine really have not done a great job of explaining to the public the difference. And I really hope someday we get rid of the term dementia, because we shouldn't be using it. We should be calling it the specific diagnosis, either Alzheimer's disease or vascular dementia or any of those particular things. And I think we eventually will move to that.
Hey, we've got a couple of questions related to alcohol. So first one, I'll just say both because I think they're related. Relationship between alcohol abuse and Alzheimer's, and what is alcohol-induced dementia, and is the diagnosis and treatment similar?
Oh, good questions. There's a lot of overlap between alcohol use and dementia in general. When it comes to Alzheimer's disease, we know that overuse of alcohol throughout our lifetime can increase the risk of Alzheimer's disease. It's also possible that someone can drink enough alcohol that it directly injures the brain and doesn't lead to Alzheimer's disease. So for example, there's kind of a rule of 35. So if somebody drinks over 5 drinks per day for 7 years, that's probably enough to cause direct injury to the brain. And that person, even after they stop drinking, will have permanent memory loss. If we look at the brain under the microscope, they don't have the brain changes of Alzheimer's disease. It's just there's so much alcohol that person has drunk that went to their brain, it directly injured their brain. On the other hand, let's say somebody drinks 2 or 3 drinks per day for many years. That probably is not enough to directly injure the brain cells, but it probably is enough that it increases the risk of the Alzheimer's disease changes, which I'll talk about in a few slides. So there's a number of ways that alcohol use can injure the brain. You may also have been told there's some amount of alcohol that's actually healthy. 1 to 2 drinks per day can be healthy. We now think that is not true. We think any use of alcohol is probably unhealthy. There is no healthy amount of alcohol. There's still some debate about that, but in general, we are no longer recommending any alcohol use for healthy brain aging.
Okay, we have another question. How to handle, oh, sorry, it just disappeared. How to handle working with a patient that refuses further testing. However, relatives tell us stories that indicate Alzheimer's disease.
Good question. We have that problem all the time. Sometimes it's very difficult. So I've seen patients many years after the family wanted them to be seen because they just refused to be seen. And when somebody has mild memory problems but can still really make their own decisions, it's pretty difficult because if the family is concerned there's a problem, the patient is not concerned, maybe because they have Alzheimer's disease and their brain is not aware of those memory changes, but the person understands that not seeing the doctor could be harmful to their health. They probably are able to make a decision to not see somebody. And in those scenarios, it's very difficult because you can't make them go. I usually encourage patients' families who ask me this question, because I do have that fairly frequently. They'll call the office and say, I want you to see my mother, but they refuse to come. And if that person, if their mother agrees to go to a doctor, you could just say, we're going to the doctor. Now, if they don't, it's up to the family whether they want to use other stories. So sometimes I've had patients' families say, oh, I'm going to the doctor, it's not you, mom. But while you're here, why don't we just get your memory checked out? I'm not advocating that, but I've seen that used. And then sometimes I've had families say, well, we're going to go to an appointment, or we have an errand to run, and you're going to come with me. Sometimes those work. I'm not trying to recommend one particular approach, but I do think it's important to try to get our loved ones evaluated because sometimes, number one, it's not Alzheimer's disease and we can fix it. Sometimes it is Alzheimer's disease or something like that, and it's important to know that, to know what may happen in the future. And third, there are treatments for each of these disorders that are different that can work. And so getting access to those treatments will be important. All right, what other questions?
I have a question about marijuana use and dementia.
Oh, okay. So the question about marijuana use is a good one. We actually do not think that marijuana use causes dementia or harms the brain or increases the risk of Alzheimer's disease. Now, smoking in general is bad. Smoking marijuana probably is less harmful to your health than smoking cigarettes. But in general, we don't think there's a direct connection between marijuana use and Alzheimer's disease.
Okay, we have a couple of caregiving questions. First one, if you're a caregiver of a relative with dementia, is there a greater risk for you of developing Alzheimer's disease?
Well, caregiving in general is incredibly stressful. Probably the most stressful type of caregiving is caring for a loved one with dementia. Study after study shows the stress for caregivers is tremendous. And that's why we're so lucky to have organizations like Lifespan in our area that can help with that, because it is so important. We do know that the stress of caregiving for somebody with dementia increases the risk of depression and other health disorders, in large part because the caregiver is so overwhelmed they can't attend to their own medical care. We also know that the stress of caregiving can actually lead to earlier death. And so that's why support for caregivers is so important. What we don't know is whether caregiving can increase the risk of dementia in the caregiver. It's possible that it could, although there's no study to prove that it does that. Other questions?
Yep, so I think you answered our other caregiving question with that. We have a question about medication use, impact of past medication use, long-term anticholinergic use, any recommendations for prevention of by avoiding those if possible?
Yeah,
That's
those
the
are good.
first one.
Okay, that's a good question. We know that medicines that are anticholinergic, so they block acetylcholine in the body, in particular in the brain, we know that those can cause memory loss on their own. There's also studies now to show that the more somebody's on one of those medicines, the higher risk of any type of dementia later in life. So we work hard to get people off of those. They're relatively safe if somebody's young, but it's still best not to be on them. And if they're over the age of 65, they absolutely should not be on them. And there's a number of lists of medicines that people over 65 shouldn't be on, and those are on that list.
Next one. How do you decide between Alzheimer's medications? Aricept, Razidine, Exelon, when is Namenda used?
Good question. I'll talk about that in just a few slides, so I'll wait and answer that question then. Are there more?
Yeah, one more question.
Okay,
There's
sorry.
so many newer meds on horizon. Today's news, even about monoclonal antibodies, work on amyloid plaques, and just, I guess, a little bit more about new medications coming.
Yep, so I'll talk about that. That's an important topic, and both a great and a somewhat difficult development. So maybe let me keep going because I think I'll probably
Yep.
get to some of those questions soon.
All right, just quickly, one question. Is there
Yeah.
any connection between ADD, ADHD, and Alzheimer's disease or dementia?
Oh, good question. There's no known connection between ADHD, which we don't use a separate ADD diagnosis. Everybody is given an ADHD diagnosis. So I'll just call it that. There's no connection known between ADHD and Alzheimer's disease, which is good.
All right, I will save the rest of the questions and you can keep going.
Okay. So Alzheimer's disease, in addition to being the most common cause of dementia, is increasing in incidence. So the numbers of people over the whole world and in the United States with Alzheimer's disease is increasing. The majority of the cause of the increase is just that the baby boomers are coming of age, meaning that they are now aging into the age range where Alzheimer's disease is more likely. And so we think that's the main reason why there's going to be more people with Alzheimer's disease over the next 20 to 30 years. That will be a great challenge for us in terms of diagnosis. We don't have enough providers to make a diagnosis, and we don't have enough support for caregivers. I mean, eventually some people will need to move into higher levels of care. We don't have enough higher level of care beds in assisted living or skilled nursing to handle all that. So we have a lot of challenges to plan for. And ultimately, the goal isn't to have to deal with that, to have to find support for caregivers or long-term care beds. The goal is to find a way to prevent and treat Alzheimer's disease so we don't have to do that. I want to talk about those risk factors for Alzheimer's disease. By far, the most common and strongest risk factor for Alzheimer's disease is age. And so that's what the graph is on the left. So if you look at somebody in their early 60s, Alzheimer's disease is actually quite uncommon as a cause of dementia. But if you look at somebody as they age into their 80s and 90s, Alzheimer's disease becomes increasingly common. And this is an older study that looked at Alzheimer's disease that causes dementia, but we now realize a good proportion of people actually have prodromal Alzheimer's disease. And so we think that over 50% of people, if they reach the age of 90, will have Alzheimer's disease. So age is a very strong risk factor. So there's something about the aging brain that leads to the brain changes of Alzheimer's disease. We really don't know what it is, and that's what we need to figure out. We know there is some impact of family history and genetics, which I'll mention. We know that there are certain genes we can test for that will increase the risk if we have it. That's that apolipoprotein E. What I think is most interesting, though, is that the same things that increase the risk of vascular disease, so whether it be stroke, heart attack, or peripheral vascular disease, the same things that increase those, the risks of those disorders also increase the risk of Alzheimer's disease. And so there's something about Alzheimer's disease that overlaps or interrelates with strokes and heart of the arteries. So diabetes, smoking, high blood pressure, high cholesterol, being overweight, especially in midlife. So in our 40s and 50s, if we are overweight and our cholesterol and blood pressure is too high, our risk of Alzheimer's disease later in life goes up. So really all of our focus for prevention at this point should really be focused in midlife, trying to prevent all of these vascular risk factors. I mentioned alcohol as a risk factor. If we don't do much, if we're not very physically active, if we have a low cognitive reserve, and cognitive reserve means that we've been nice to our brain, we've exercised our brain, we treated all those vascular risk factors, and didn't overuse alcohol, we think that our brain cells have extra brain cells as backup because we haven't injured them throughout our life. And so when those Alzheimer's disease changes occur, we're less likely to show symptoms of Alzheimer's disease. And we should avoid head trauma, but I think that's a pretty straightforward idea. So I now want to talk about what Alzheimer's disease is specifically and why it is that we can now test for it, maybe treat it, and how it's different from other dementias. So this is a brain of somebody who passed away from Alzheimer's disease. If we take a piece of their brain and we look at it under the microscope, we see this. So we see two things in particular. These blue arrows are these amyloid plaques. They're outside the brain cells. This is a brain cell, and they're humongous. So brain cells are actually pretty big cells in the body, but these amyloid plaques are huge, and they're big clumps of this amyloid protein. These brain cells are actually not meant to be black. They're meant to be pink. And so this is a brain cell that's injured by a neurofibrillary tangle. So these tangles build up inside the brain cells. These plaques build up outside the brain cells. The tangles and plaques you've heard about, I'm sure. So plaques and tangles is a common phrase when it comes to Alzheimer's disease. And so that's why you hear that term. But the microscopic pictures, so the pictures under the microscope of Alzheimer's disease, really don't give us enough information about the cause of Alzheimer's disease. So that's what this very complicated next slide is. And I want to walk through it because it really helps understand the cause of Alzheimer's disease. So if I start way over here in the bottom right, this is our the surface of our brain cell. This is actually the membrane, the surface of the brain cell. This APP is an amyloid precursor protein. We have enzymes in our body, in our brain, that work like scissors, and they can cut, so it cuts the red piece apart, or they can cut it in another way where we have two different sets of enzymes that eventually break apart this red fragment of the amyloid precursor protein. This red fragment is the amyloid beta piece of the protein. We don't understand what the amyloid precursor protein does. We don't understand what the amyloid beta piece does and why it gets broken apart. There's a lot of theories, and I think we're closer, but we don't really know. There's something about this amyloid protein that's really sticky. So they start to clump together in 2s and 3s, and eventually in 10s and 20s. Those are called oligomers. Then they get bigger and bigger, and fibrils are even bigger clumps. And eventually they get so big, they form these plaques. And that's what the amyloid plaque is. It's this piece of the amyloid precursor protein that gets sent inside the cell and eventually outside the cell. And when it gets sent outside the cell, there's more and more and more of these, and it forms these huge plaques. Somehow, and we don't understand how, these plaques, we think, lead to all these other changes, including activation of the immune system, direct injury to brain cells because they are overactive. This tau protein becomes phosphorylated. That's that thing I talked about, the modification of the tau protein, and they deposit inside the brain cells. They injure brain cells, and our brain cells can't communicate. Our brain cells die because of all the tangles. We can't make the chemicals that our brain uses to communicate, and eventually it leads to Alzheimer's disease. So obviously our goal should be to work on some of these processes, trying to stop the amyloid protein from being made, getting rid of the amyloid protein, working on all of these, and all of those things I mentioned are part of active research right now. In particular, these two medicines that have just gotten approved, lecanemab and aducanumab, are meant to get rid of these early forms of amyloid beta. And they do that by attaching to them because they're antibodies, and then our own immune system gets rid of them. The medicines we also have right now, the Aricept and Namenda type medicines, they work way down here on this phase where they give us some chemicals back that let our brain cells communicate better. And obviously they're not what we need. They're not effective enough, and they don't affect any of this process. And they work way too late in the process to make a big difference. And that's why these new medicines are so exciting. Let me come back to that later because I think it's going to make it a little confusing. So I want to talk about the genetics of Alzheimer's disease. So there are a number of genes that are very uncommon. Less than 2% of people who have these genes will have Alzheimer's disease at a young age. It's very uncommon and one I don't talk about a lot. What I do want to talk about are those ApoE genes, because you may hear about them in the news with these newer medicines. So having certain types of those genes can increase your risk of Alzheimer's disease and may increase the risk of some of the side effects of these new medicines. So more and more we're testing for this gene because we're using it to make decisions about the new medicines. So the question is, what does all of this mean? So I talked about the plaques and tangles, and actually how the plaques and tangles are caused by a whole cascade where the amyloid precursor protein is broken apart into the amyloid beta piece. That causes the plaques. Somehow it leads to the deposits of tau, the protein tau, inside the brain cells, and it injures brain cells. What's interesting is, for whatever reason, the process of injuring brain cells because of the tau and the amyloid starts in the memory center of the brain. And that's why the shrinkage of the memory center of the brain is so important. So I mentioned on the poll, what is the meaning of the shrinkage of the memory center of the brain? The reason that's important is, for some reason, all of these brain changes of Alzheimer's disease affect the memory center of the brain first. And so because of that, the by far most common symptom of Alzheimer's disease is forgetfulness. So an inability to store new memories that leads us to misplace things, repeat ourselves, forget where we're going in the car, forget our appointments. And that's the most common symptom of Alzheimer's disease. So I'm actually going to go back to this graph and make the point that most patients come to see us and get a diagnosis of Alzheimer's disease here. But we now realize that patients who end up here start having the brain changes of Alzheimer's disease way back here. And we now realize that spinal fluid tests or PET scans can pick up these brain changes sometimes 10 or 20 years before the person actually is given a diagnosis of dementia. And we understand that the amyloid beta protein deposits first. That starts to affect our brain cells' communication. Somehow the tau protein starts to deposit inside the brain cells, and it injures brain cells, and so we can see shrinkage of the memory center of the brain. And only after that happens do we start having effects on cognition, on memory, and those start very subtly, and only when they get more severe does it impact their overall function, and we call it dementia. And so this category of mild cognitive impairment, for many people, is the beginning stage of symptoms of Alzheimer's disease. The difference between mild cognitive impairment and dementia is somebody with mild cognitive impairment has deposition of the amyloid protein, they have deposition of the tau protein, the memory center of their brain has started to shrink, but they've been able to adapt to those very subtle brain changes. They may have forgetfulness on testing, but they can still find a way to manage their finances and their medications. And so by definition, they don't have dementia, they have mild changes in cognition. But we now realize that for many of those patients, they actually have Alzheimer's disease of the brain. When we do these lumbar puncture, spinal fluid analyses, these fancy PET scans, we now see those brain changes of Alzheimer's disease. And so I think we're also eventually going to change so we don't have a term of mild cognitive impairment. We do specific tests looking for Alzheimer's disease, and either it's the early stages of Alzheimer's disease or it's something else. Let me stop and see if there's more questions before I start talking about treatment.
Sure. So we have a question about herbal use in memory loss. If you're familiar with any herbal uses and
So
impact on memory loss.
yeah, so what about supplements? And I'll sort of widen it to supplements. So are there supplements that can either improve memory, prevent Alzheimer's disease, or treat Alzheimer's disease? The answer is we don't know, but so far every supplement they've tested does not appear to be effective. So ginkgo biloba was studied. It doesn't appear to prevent Alzheimer's disease or improve memory. Fish oil is the same. That doesn't mean there aren't any, but so far all the ones they've tested haven't been helpful. They're currently looking at things like coconut oil, resveratrol, which is a chemical in red wine, and a number of other things. Turmeric, I think, is being studied. So there may be supplements or herbal supplements that actually will be helpful. We just don't know.
Great. There's a question about hereditary. Example, a mother died of dementia. Now her daughter has dementia.
So the question is, could it be inherited?
Yes.
Yeah. We know that less than 2% of people with Alzheimer's disease have a gene that makes them inherit Alzheimer's disease. However, if somebody has frontotemporal dementia, it's actually much more likely to be inherited. If somebody has dementia with Lewy bodies, it's almost never inherited. So the most important thing to figure out is what's the cause of someone's dementia. So when I get that question from patients and families, the first question is always, do we know anyone in the family for sure, the cause of the dementia for sure? Has there been an autopsy? Has there been a gene test? Has there been a spinal tap? And without those, you really don't know. So I've had a lot of patients come to see me with a family history of genetic Alzheimer's disease. It turns out no one in the family has Alzheimer's disease. It's frontotemporal dementia instead, because the diagnosis in the past was so uncertain.
Another question, can brain cells reproduce or can new brain cells be recreated?
Only a little. So it turns out that we have the majority of our brain cells when we're born. We do grow a few additional throughout our lifespan. Our brain is at its peak at about age 26. That's the best our brain's ever going to be. And then it starts to decline after that. And we tend to only lose brain cells. Things like physical activity can actually improve that and can actually regrow some brain cells, but it's very small. And so for the most part, we can't regrow them.
Okay, we have a question. It's not letting me see it. Had an MRI done. Sorry, it's not letting me see the whole message. Let's see if I can get it.
Let me see if I can see it on my end.
I had an MRI done on my brain due to headaches. Could that scan be used to look for dementia is what I'm.
We do occasionally have patients sent to us who have an MRI for another reason, and it shows a lot of shrinkage of the brain, and somebody's worried that it's dementia. All of our brains shrink as we age, and so oftentimes if somebody comes to see us with that concern, the most important thing is to do the MRI with those automated measurements, because they don't do them unless you ask. So sometimes they come to see us and we repeat the MRI with those measurements, and it turns out it's perfectly fine for their age.
Have they found that those games on the computer phone that are brain teaser type games helpful to prevent dementia? I've heard that it does, but want to verify.
A little bit. There's really 4 or 5 things that have pretty good evidence behind them that may prevent Alzheimer's disease or other causes of dementia. These are things we can do throughout our lifetime before memory problems start. So being physically active, being social, doing things that challenge our brain, and following a heart-healthy diet like the Mediterranean diet. So the computer tests would help with the cognitive activity. So exercising our brain. The truth of the matter is, though, things like computer exercises probably are not real engaging for our brain. And so it's better to do things that engage our brain with other people. So reading a book is great, but a book club is better. Playing cards is great, but in a card club and playing with other people is better. They're much more challenging for our brain. So brain games and brain exercises, I think, are great, but it should only be one piece of what we do. And it really should be trying to do things with other people. That should be a goal.
One more question for right now. Anything that you know about lion's mane?
Oh, well, lion's mane get a lot of questions about. I think that's a mushroom supplement. And I think those are being studied. We don't know if they work or not. Mushrooms are amazing organisms, and they have very interesting chemicals in them. So it is certainly possible that they're going to have some benefit. I think we just don't know.
One more question. Will testing for Alzheimer's disease ever become standard?
I think so. I think once the blood test comes out, initially it's going to be incredibly expensive and not covered by insurance, but over time, hopefully it will, and they'll make it cheaper. And so I think that at some point, almost everybody will come to see their doctor over the age of 65. And if they or their family are concerned about their memory, they're going to have the blood test. And then the question is, what about treatment? But I think that's very likely going to happen. Right now, the process is if you go to your doctor over the age of 65, pretty routinely they'll do a screening test for cognition, for memory problems. And if it turns out there's a problem, then will do more tests.
Thank you, Dr. Gill. That's all we have for.
Okay. So this next graph I like. It's just a theoretical graph, but I think is very accurate. So when we see somebody with Alzheimer's disease in particular, when we look back and when their symptoms and when they started, people often will start with some change in their mood where they feel down or anxious, even before the memory problems start. It starts to be bad enough to affect their overall function, and then the behavioral issues start. And only at the very end does it affect their ability to get around. And that's helpful to remember that mood symptoms often start early, memory problems start next. Only after that are there behavioral issues that might be agitation, sundowning, hallucinations. They don't always happen, but often do, but they don't happen early. And somebody shouldn't have problems getting around early in the stages of Alzheimer's disease. Let's talk next about treatment of Alzheimer's disease. The first three medicines are the Aricept type medicines. There's three companies who make a very similar medicine. They all give acetylcholine back to the brain that's involved in memory formation, and they can help improve our memory a little bit. Amantine works on a different chemical that's involved in memory, and again, it can help memory a little bit. These do not prevent Alzheimer's disease. They don't slow down the process of Alzheimer's disease, but they're meant to improve memory a little bit. So I always tell people if Alzheimer's disease causes a big problem with memory like this, they help a little bit like this. The majority of the time when I use them, the person comes back to see me and says, I'm not sure if it's helping. So it probably helps a little bit, but nowhere near what we need. We offer them to everybody with Alzheimer's disease. If people choose not to take them, it's certainly their right and their opinion to not use it. Because it doesn't slow down the process or prevent Alzheimer's disease, there's no reason we push hard to make sure somebody takes them. And so it's something we discuss with everybody, but not everybody chooses to take one of those. The most common side effect is upset stomach or diarrhea. When it occurs, it can be bad and often limits the use. These new medicines, aducanumab and lecanemab, are IV infusions that are antibodies against the amyloid beta protein. They're meant to get rid of the amyloid beta. They attach to the amyloid beta in the brain. Our immune system sees the antibody, seizes lecanemab or aducanumab, and it says it's not meant to be here. It gets rid of that antibody, and because it's attached to the amyloid beta protein, it gets rid of it as well. The graph on the right is what is a typical response we're seeing now from these medicines, where patients still decline, but they decline less rapidly. So the person normally would decline like this on the green graph, and with these medicines, they're declining less. But most patients are still declining. And so the discussion we're having with patients is whether the medicines are worth it, given that they don't prevent all decline. These medicines right now are not covered by insurance, and they're about $26,000 to $27,000 a year. And so we can't use them for most patients. They also have significant risks of brain swelling and brain bleeding. And so a lot of debate right now, because Medicare and Medicaid are not covering them outside of research studies, right now we're really not using them much. I think the Medicare and Medicaid is going to look at this in the summer. If these are covered by Medicare and Medicaid, it'll greatly change how often we use them. And I think a great number of people are going to be interested in using them. There's many non-drug treatments that can be used as well, and we talk a lot about these with our patients. So being active in general, supportive care for caregivers, programs like this, focused memory rehab are all helpful. And so it's important to know that there are things that can be done that aren't just medications. When it comes to behaviors, there are no medicines that are first line treatment for behaviors. We sometimes have to use medicines, but we talk a lot about behavioral management where you use things like this tool to prevent troubling behaviors. And both last year and this year, Lifespan has sponsored a really great program based on an experience we had with a patient with aggression. We wanted to do something for the community to help prevent that. And so I really appreciate Katie and everybody at Lifespan creating this program. And we're going to do it again this fall. So keep your eyes out for this. The October 12th and November 2nd is last year. So be on the lookout for the ones for this year. Okay, let me pause again to see if there's any questions. Maybe not. Okay, I'm going to keep going. I'm actually going to skip this case. I had it there just in case we hadn't covered mild cognitive impairment already, but we did. So just in the interest of time, I'm going to skip that one. I talked about ways to prevent Alzheimer's disease and dementia already, so we can skip that. I always spend the most amount of time on Alzheimer's disease because it is so common. So now I'm going to talk about another two disorders. So this is another real case. So Jenny's 71. She's concerned about her memory. Her story is different from Harold. So Jenny lost the ability to dance about 8 years ago. Something happened. She was able to dance, an active dancer, but somehow she just became clumsy and couldn't do it. About 3 years ago, she went on a trip and came back and suddenly noticed she couldn't talk. She couldn't come up with words, and that didn't really improve, not a lot. When you see her on exam, she has difficulty coming up with words. She can't pay the bills. She has difficulty with her memory, and she seems to have balance problems. Her father had Parkinson's disease. On the examination, you find that she has difficulty with memory, difficulty producing words and saying words, and it looks like she has difficulty with weakness on the right. Here is her scan. Her scan looks a little different because we see a lot of whiteness here. And the whiteness is probably prior hardening the arteries or strokes. And so same question for her. What's her diagnosis? Let me relaunch this. I think people have figured me out. So all right, so most people came up with the right answer, which is vascular dementia. So her story's clearly a decline that occurs like this. So she's doing okay, and then something happens, and then she does about the same, and something happens. And that's because she likely had strokes that affected her balance. She couldn't dance, strokes that affected her talking, and she couldn't talk. And so her category, her diagnosis is vascular dementia. And the main point I'm going to make for vascular dementia is just this slide and one other slide. I included some others for reference, but the point is that vascular dementia is really not one thing. As I mentioned at the beginning, it's any blood vessel problem that affects memory. And so there are people like Jenny who have what we call multi-infarct dementia. That an infarct is a stroke. So they're doing okay, and then they decline. And they're doing okay, and then they decline. But that's not everybody. In fact, very few people present to our clinic with that exact story. It's more common that they come through stroke clinics. So somebody has a big stroke. They have a stroke that affects their talking and their right side, and they can't walk anymore. And only after they've recovered from the stroke and have gotten some of their movement back, do they find that their cognition, their memories affected. There are other people who have no history of strokes, but come to us with a scan just like Jenny, where there's all this hardening of the arteries, but looks like vascular disease of the brain. And that probably is long-standing heart of the arteries due to diabetes and high blood pressure. Then there are these unusual disorders that can be inherited that cause strokes. That's called CADASIL. And then something called amyloid angiopathy. I want to point that out because it often leads to bleeding of the brain called intracerebral hemorrhages. And that amyloid protein, you probably remember, is the same protein that causes Alzheimer's disease, or at least part of the cause. So the amyloid protein can also build up in the blood vessels of the brain and cause injury to the blood vessels. And when that happens, it leads to this. And so all of these are black spots that are prior bleeding of the brain. And then sometimes it causes massive bleeding of the brain. And on the scan on the right, you can see injury to the brain where those black areas are the back of the brain. And it's caused massive injury from bleeding into those areas. The amyloid angiopathy, if somebody has that, it makes these new medicines unsafe. So the aducanumab and the lecanemab medicines unsafe. And that's another reason I want to mention it. There are medicines that can be tried, but they're the same medicines we use in Alzheimer's disease, and they don't routinely work. So we often will offer it, but we don't recommend it. I'm just going to make a point with this slide before I pause again for questions. And the point I want to make here is there are some patients who have very clear vascular dementia. They've had a big stroke and it causes dementia, but they have no progression over time. There are people over here who have just Alzheimer's disease. They have no strokes on the scan at all. But most patients we see are somewhere in the middle, where they have some heart of the arteries and Alzheimer's disease, or they've had a stroke and they're getting worse without a new stroke. And so many of these patients actually belong in the mixed dementia category, which for most people is a combination of Alzheimer's disease and vascular dementia. And I just point that out because it's so common for us that somebody doesn't fit neatly into one category. All right, let me pause for questions again, because I think there might be a couple.
Yep, supplement with CDP choline. That's all it says. So I guess
Yep.
any
So there are
input you
supplements
have.
that have these choline derivatives, and some of them are actually acetylcholine, and they may work in a similar way to Aricept. So it's possible that some of those supplements might be helpful. They're not as focused as medicines like Aricept, so don't routinely recommend people use them instead of Aricept. But they haven't really been studied, so we don't know much about them.
Eli Lilly donanemab.
So donanemab is one of these new medicines. I didn't include it because it's not FDA approved, but it works in just the same way as lecanemab and aducanumab, so you can think about it identically to those.
All right. Is there any link between dementia and chemotherapy or radiation?
So we now know that chemotherapy in particular can affect cognition, and we call that chemo brain because there isn't a better term. We don't think it increases the risk of dementia and things like Alzheimer's disease later, but we're not really sure about that. Radiation, if it's for the brain, definitely affects cognition. We work hard to avoid whole brain radiation if we can these days because we know it almost always affects cognition. We don't know if it causes this Alzheimer's disease process or not, though.
Another one from Marianne, any correlation between Down syndrome and Alzheimer's disease? I have a 39-year-old mildly retarded son who is sometimes uncharacteristically forgetful, but remembers things from long ago.
There is a very strong link between Down syndrome and Alzheimer's disease. The amyloid precursor protein is on the same chromosome that leads to Down syndrome, and they have an extra copy of that chromosome. So 100% of people with Down syndrome, if they live long enough, will develop Alzheimer's disease. However, most patients that we see with Down syndrome in clinic who have a change in behavior, it's not due to Alzheimer's disease, it's due to something else, some change in staff or other situation. most patients that we see with intellectual disability, any environmental change is really difficult for them. So if they move group homes, or there's a change in staff or change in the day program, it's really difficult for them. And so the good news is the majority of the time we see people, it's not Alzheimer's disease, but sometimes it is.
I think that's it for now.
Okay, so these last two cases are something different. So Sam is 56, and he came to see me for two reasons: forgetfulness, but also a tremor. The tremor is in his right arm. Both of these have worsened over the past several years. And so now, in addition to forgetfulness that impacts his overall function, he also has a tremor and slowness of movement on the right side. He also tells you that he frequently sees people who've passed away in the room with him. They don't talk to him, but they're there with him, especially at night. His son says that he's been acting out his dreams in a violent way for a number of years and has a very poor sense of smell. His exam shows slowness of movement. We call that bradykinesia, a tremor when he's sitting still and on his right side, as well as some slowness of movement, along with the issues with memory. Here he is. And you can see a tremor really in both sides, but more prominent, at least in the video, on the left, but he began on the right. You also see at the very end of the video his face here. In his face, there's not a lot of movement in his face. It's a slow moving face, not a lot of facial expression. His lab work is normal. His MRI looks quite normal. And so the same question I've asked before is, what is this? All right, so most of you figured me out again, which is good. So this is somebody with dementia with Lewy bodies, and there are a number of things that are important in the acting out of dreams and poor sense of smell in particular. So let me get to that. So Lewy body dementia, this is the criteria for Lewy body dementia. And it's important to have the following. So dementia, which means bad memory, progressive cognitive impairment, visual hallucinations, which he had, Parkinsonism, which is the tremor and slowness of movement, acting out dreams in his sleep, and the other is fluctuations. And that's where somebody throughout the day has these times where it seems like the person's just not with it at all. They close their eyes and stare up into space. Those are all very suggestive features of Lewy body dementia, which is different from Alzheimer's disease. If somebody has all of these features, we can be very certain that they have Lewy body dementia, over 80% certain actually. And what are these Lewy bodies that I talk about? So Dr. Lewy was a guy, a pathologist, who described these in the brain under a microscope. This is a brain cell that's the pink it's supposed to be, but in addition to the pink, it has these big circular globs. These are Lewy bodies. They're mostly an alpha-synuclein protein that deposits in the neurons, so in the brain cells. It deposits in the brain stem. It actually starts down here at the very bottom of the brain stem, and that's what allows us to be paralyzed during sleep. So we actually realized that patients who go on to develop dementia with Lewy bodies often start acting out their dreams in their sleep in a violent way for many years. And so somebody comes to see us who's had years worth of punching or hitting their wife or husband in bed, and now they have that slowness of movement and forgetfulness, we can be pretty certain that it's dementia with Lewy bodies. But we now realize that dementia with Lewy bodies is more than just a brain problem. So in addition to the deposits of these Lewy bodies in the base of the brain stem that progress up into the brain and then affect the whole brain, These Lewy bodies actually deposit in the nerve to the nose and the nervous system of the gut. And so we realize patients with dementia Lewy bodies actually start having constipation, poor sense of smell, even before they start acting out their dreams. And so when somebody comes to see us with poor sense of smell and they act out their dreams, that is very suggestive of dementia Lewy bodies, because these don't happen in Alzheimer's disease. And so asking about those things can be very important. And I'm sure if any of you have loved ones with dementia Lewy bodies, you'll notice that these things have happened. Dementia Lewy bodies causes the cognitive impairment, the memory problems, the slowness of movement, but also causes autonomic dysfunction, which is trouble maintaining blood pressure when we stand up, trouble holding control of our bladder, and the hallucinations, fluctuations, and a number of other things. And so these are all very unique to dementia Lewy bodies and so important for us to know when we make a diagnosis. There are a number of medicines we use to treat dementia Lewy bodies. None of them were invented for dementia Lewy bodies. So the treatments are all targeted at the symptoms. So if somebody has slowness of movement and tremor, the medicine we use for Parkinson's disease can be helpful. The same medicines we use for Alzheimer's disease can improve memory. Even though this has not been approved for use in dementia Lewy bodies, ironically, medicines like Aricept can work quite a bit better for dementia Lewy bodies than for Alzheimer's disease. If somebody has hallucinations, we have medicines that can treat it, but it's very important we use what are called atypical antipsychotic medicines, because the ones that are older are called typical. Those are things like Haldol. They actually block medicines like levodopa, and they block dopamine in the brain and can cause somebody with dementia Lewy bodies to be much worse. The typical antipsychotic medicines may be safe in somebody without dementia Lewy bodies, but are very dangerous in somebody with dementia Lewy bodies. So one of many reasons why it's so important for us to know the right diagnosis. And then there are medicines that can stop somebody from acting out their dreams in their sleep. We also have an ongoing program through the Alzheimer's Association, which is a caregiver support program and a support group for patients with Lewy body dementia. All right, I know I breezed through that kind of quickly. Let me stop and see if there's questions. I just have one more topic before we're done.
We do. We have a hand up. Delia, I see you have a hand up there if you want to unmute and ask your question.
Oh, I want to know how important it is for a person that has memory loss, can't find their keys, doesn't get to appointments on time, does go to the doctor, how important it is for them to get a diagnosis.
I would say it's, go ahead.
Should they push to get a diagnosis or just?
Yeah, absolutely. First of all, this may be part of normal aging. It may not be more than that. So first of all, how much of a problem is it? But secondly, it's important because there may be something else that's not one of these things. Maybe it's a low B12 level, or their thyroid is over or underactive, and that's very treatable. Maybe there's a stroke that needs to be found, and they need to figure out why the strokes are happening. That's another reason. A third reason is we want to know what's going to happen in the future. Is this Alzheimer's disease, and is it going to get worse? And if so, we should plan for that. And then the fourth reason is there are medicines that can treat some of these, but they really only treat one or two of these, not all of them. And we shouldn't just be randomly using Aricept for some patients. And so knowing the underlying cause can really help us figure out how to treat it, especially with these new medicines that are only going to work for Alzheimer's disease. We should try to figure out the cause to know how to treat it.
Thank you.
Thank you. One more question, Dr. Gill. Issues with smell, are those also related for people with Alzheimer's disease?
So somebody with Alzheimer's disease does have changes with their brain's ability to understand smell. You may have heard about this sniff test with peanut butter and whether it can help diagnose Alzheimer's disease. That likely is because the brain has a hard time figuring out the smell, but their ability to smell is much better than somebody with dementia Lewy bodies. They have really no sense of smell because the nerve to the nose has been injured.
And One more question popped up. Is there any link from Alzheimer's disease and constant diarrhea?
Well, the link would be if somebody's on Aricept or one of those medicines. So if somebody's Alzheimer's disease and they're on Aricept, which is donepezil, galantamine, or rivastigmine, they should stop those medicines because it's from the medicine. There are a number of things that can cause diarrhea and dementia. They're uncommon, but that's one of the important reasons to make sure that's been evaluated. So for example, celiac disease can lead to diarrhea, but also cause dementia. So that'd be something to look into.
Right, I think you can continue.
Okay, great. All right, so this is the last case. This is a patient who came at the request of his wife. He comes alone, and this is the story that he tells. I'll let this play a little bit, but I won't play the whole way through.
Tell me a little bit more about what brought this all to attention.
Mostly my wife.
Oop. There we go.
What did your wife say was the matter?
Oh, I wasn't paying attention during my driving, and things around the house wasn't getting done. Things like that.
Now, have you been working?
No, they've got me on medical leave right now.
What's your occupation?
I'm a telephone man. I work in the central office.
And did this condition cause you any difficulty at work?
No, I didn't think so, but evidently it did.
Why do you say that?
Because they put me on medical leave.
At work?
Yeah.
Okay. Did you get some negative evaluation from a supervisor?
No.
No.
I'm just going to stop it there to make a point that this patient, the way that they present themselves, is very difficult different from somebody with Alzheimer's disease. No problems coming up with words, seems to be aware of what's going on. It makes it very difficult to figure out the story because the story he says is pretty straightforward and there's really no problems. Now, if you talk to his wife, the story is very different. He's a telephone operator and he did have difficulty at work. And most importantly, with his wife, there's been quite a change in their relationship. He used to be very loving and understand that she needed things like birthday cards and other things. But he has stopped doing all those. And so the biggest change isn't with thinking and memory, but more with emotions and his inability to understand that someone else has emotions and he should react to those. His MRI is quite striking. It shows prominent frontal and temporal lobe atrophy. And in the interest of time, and because it would be clear which this is, I'm actually going to not do the poll, but this person has frontotemporal dementia. And frontotemporal dementia is different from Alzheimer's disease. There actually is a test that's fairly accurate in making a diagnosis. That's a type of PET scan. The same type of PET scan is used for cancer, which is a glucose, a blood sugar PET scan. And the reason it's so accurate is that on the top is somebody with Alzheimer's disease that shows lack of activity in the back of the brain. Somebody with frontotemporal dementia has lack of activity in the front of the brain. And so this test is something we use quite commonly in our clinic. But I just wanted to show these couple slides to show that when people have underlying frontotemporal dementia brain changes, they don't present just like this gentleman with behavioral changes. They can present with trouble talking, with Parkinsonism that looks similar to dementia Lewy bodies, or even things that look like ALS, Lou Gehrig's disease, as I mentioned before. And so we have to be really careful when we see somebody when they come in with Parkinsonism or they come in with trouble talking, because it could be either frontotemporal dementia or Alzheimer's disease. And so doing these additional tests, whether it be a spinal tap, a lumbar puncture to look for Alzheimer's disease, or an FDG PET scan is very important. It's also important because the symptoms, in particular of the behavioral presentation of frontotemporal dementia, can be very difficult to, different from Alzheimer's disease. There can be behavioral changes with frontotemporal dementia, which are not present in Alzheimer's disease. Their memory can be fairly normal. They can be very inappropriate in social situations and have no empathy. And so they can have a lot of unique challenges from somebody with Alzheimer's disease. It's also much more common in somebody who's younger. So if you remember the graph I showed you about Alzheimer's disease, in somebody's 60s, it's very uncommon. If somebody's in their late 50s, early 60s, frontotemporal dementia is much more common than in somebody's older. The other big challenge we have is if we look at their brain under the microscope, there are many different causes of frontotemporal dementia. I went through that whole slide talking about the brain changes of Alzheimer's disease that we think everybody with Alzheimer's disease has. Right now, we think that frontotemporal dementias are probably more than one thing. And that's why I said we call them frontotemporal lobar degenerations now. It can have deposits of the same tau protein or TDP43 or some of these other proteins. And I think we're just starting to understand what frontotemporal dementias are. And we're eventually going to say all these things are different. They're different diseases. And so there's a lot more to come when we find out about frontotemporal dementia. Again, because it's so different from Alzheimer's disease, we run a very similar program for the people who care for patients with frontotemporal dementia. Okay. I know I kind of rushed through some of those last slides. I did want to leave a few minutes for questions before we have to wrap up at noon. So are there questions that I could help answer?
Sure, we have a couple more questions. If the side effect of diarrhea is experienced from medication, does it resolve? Do you decrease the dose, or does the medication have to be discontinued?
It does not improve. We tell patients that if it happens, and especially if it's bad, you just have to stop the medicine. One of the drugs, the rivastigmine, is available in a patch, and sometimes the patch causes fewer upset stomach and diarrhea side effects. So we do sometimes stop the pill and try the patch instead. But for some patients, even the patch causes horrible diarrhea, and we just cannot use those medicines.
Thank you. If a neuropsych evaluation calls it Alzheimer's disease, how important do you think it is to do further testing? For example, CSF fluid or PET scan, other
Good
tests?
question. What we tell people is if the story and the MRI and the neuropsychological testing all looks like Alzheimer's disease, we can be, like I mentioned, about 80% sure. And there probably is very limited benefit to doing additional tests. So if the spinal tap is 90% certain, but we're 80% certain already, probably not worth going through the discomfort of a spinal tap. And so for those patients who we're pretty certain have Alzheimer's disease, we do not recommend a spinal tap.
Great, thank you. If someone has COPD, can it result in frontal lobe dementia?
It should not. So COPD is a lung disorder often caused by long-standing use of or long-standing smoking. But we think there shouldn't be any injury to the brain because of that.
And can a person have both frontotemporal and Alzheimer's disease?
They can, but it's very uncommon. The most common overlap, as I mentioned, is Alzheimer's disease and vascular dementia, so hardening the arteries or strokes. The next most common overlap is dementia with Lewy bodies and Alzheimer's disease, but it's incredibly uncommon to have both frontotemporal dementia and Alzheimer's disease.
Great. There's a question that says, what if someone does have constant diarrhea, but is not taking many medications and none for Alzheimer's disease?
Yeah, they definitely need to see their doctor about that because there may well be a medical cause that needs to be figured out.
I don't see any other questions. We do have a survey. Mara just put the link in the chat, and we would love for you to go ahead and let us know how we did today, what other types of sessions you'd like to see. We also rely on donations to make events like this possible, as well as other programs and services at Lifespan. There are ways to donate both online at our website and also Venmo at at Lifespan-Rochester. And we have several additional sessions, as I mentioned, coming up. On next week, we have Dr. Carol Podgorski talking about which hat am I wearing, the many different roles of being a caregiver. We'd love you to join us with that one as well. That is online. She is actually one of the people who also will join Dr. Gill in the fall for our kind of aggression series, along with Dr. Bruns. And we, again, are so grateful to have you with us today. We encourage you, if you are a caregiver, to give us a call if there's anything we can do to support you. We have care management, wellness classes, education, support groups, respite, and so much more. I did want to mention briefly before you all head off that we do have a new drop-in respite program open, running on Tuesdays at the Phyllis Wheatley Library from 11:30 to 3:30. It is free. You do have to register. You can call us at 244-8400 and ask for Dawn. Dawn will go through the eligibility to attend that program and get folks registered, but that is a free respite opportunity. We've got some really great activities going on with Dawn, other staff and volunteers, and would love to be able to provide that as an opportunity for the people you're caring for and give you an opportunity to take a break. We're also looking for volunteers for that. Any other, I don't see any other questions. If not, thank you all so much for joining us, and we hope to see you again. And Dr. Gill, thank you so very much for sharing your knowledge and expertise with us.
Sure. Yeah. Thank you very much for having me. I really appreciate it.
Okay. And again, please do the survey if you can. The recording will be available on our website, and we will send the slides out to everyone. Thanks so much. Have a great day.
Bye-bye. Thank you.